Good afternoon, everyone. This is the March 12th, 2026, 12 p.m. meeting of the SURG Statewide Substance Use Response Working Group's Response Subcommittee. So I wanted to welcome everyone to the meeting and make sure you're at the right meeting. So we'll go ahead and move to the next slide. I just want to start out by saying that the SURG and its subcommittee can take agenda items out of order, can combine two or more items for consideration, or remove an item from the agenda or delay discussion related to an item at any time. We're pleased to make reasonable accommodations for members of the public with a disability who wish to participate. If accommodated arrangements for the meeting are necessary, please notify Vicki Beavers. She's the executive assistant to the AG, 775-684-1212. And she's at the 100 North Carson Street, Carson, Nevada office. Or you can email your request to beavers@ag.nb. We can go ahead and start with our call to order and roll call to establish quorum.
Thank you, Chair Kearns. Crystal Duarte for the record. I will call the roll. Please note if you are present. Rob Banghart.
Present.
Peter Handy.
Present.
Nicole Hicks. I'm going to say Ms. Hicks' name again, and then maybe we can come back. Nicole Hicks. Okay, I'll come back to that. Dr. Shayla Holmes. Dr. Terry Kearns.
Present.
Christine Payson. Bud Shaw. Bud, do you mind acknowledging again? We just didn't quite catch that, but I saw you come off mute.
Yep, present.
Thank you. Senator Jeff Stone. Okay, and I'm going to go back to, because I do see her name here, Nicole Hicks.
I'm here, present. Sorry about that. I'm driving and I don't know how to work Zoom as well on my phone. So I'm like, how do I unmute it? But yes, I'm here. Thank you. Sorry.
No problem. Thank you so much. With 5 members present, we do have a quorum.
Thank you, Ms. Duarte. Just of note, if one of the committee members must depart the meeting prior to adjournment for any reason, that member should formally announce their departure for the record to ensure accurate minutes and to allow the chair to confirm that a quorum remains in accordance with our state's open meeting law. So we'll move on to the next agenda item, which is agenda item number 2 for public comment. Public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. No action may be taken upon a matter raised under this item on the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken. And I would highlight also, please do not use the chat for items other than a technical support, as this becomes part of the public record, and the meeting chat functionality is limited to inquiries regarding technical difficulties or to indicate an interest in offering public comment. Exercise caution with links which may appear in the meeting chat as they could be malicious. So if you are dialing in from a telephone, dial 719-359-4580. When prompted, enter the meeting ID of 884-0825-1817, and please press *6 so the host can prompt you to unmute. And members of the public are requested to refrain from commenting outside of the designated public comment period unless specifically called upon by the chair. Do we have any public comment? I do not see anyone unmuting, and I don't see any hands raised.
I don't either.
Okay, and we will have another public comment session at the end. Oh, did someone have public comment?
Mr. Shaw, did you wish to make public comment?
No, not at this time, sorry.
No problem.
Okay, I just wanted to ensure we gave someone the chance if they were trying to speak up and we missed them. As I mentioned, we will have another public comment at the end of the meeting. We will now move on to agenda item number 3, which is to review and approve minutes from the February 3rd, 2026 Response Subcommittee meeting. Is there any discussion, first of all, on the minutes? Seeing none of the committee members raise their hands, I just wanted to make one slight change on page 4 of the minutes. The second paragraph that starts with Dr. Holmes, then shift it. It's that paragraph. It's the last sentence, which is this subcommittee would repeal that section of NRS. I think it should say, if the recommendation is approved and becomes current legislation, that would repeal that section of NRS, because our subcommittee wouldn't be repealing it, but the recommendation approval and becoming legislation would be the repealing of the information that's already in NRS. Is there any question or comment to that change that I suggested? Hearing or seeing no hands raised, I would request a motion to have the minutes approved with that edit.
So moved. Bud Shaw.
Thank you. Motion was made by Bud Shaw. Any seconds?
Nicole Hicks, I'll second the motion.
Thank you. And Nicole Hicks seconds the motion. At this point, we will vote on the committee meeting minutes. So all in favor, say aye. Aye.
Aye.
Any opposed? And any abstentions? Hearing none, we have approval of the February 3rd, 2026 Response Subcommittee meeting minutes, which will allow us to move on to agenda item number 4.
Crystal Duarte, for the record, if it's okay, Chair Kearns, I was just going to note, I think that's the only motion likely to happen on today's meeting. But when a motion is called for, if it is made or seconded, if it is okay, if members can please repeat what the motion is so we're clear what motion is being made. That would just help us out. So I think we're fine on that one, but I just wanted to note that for future meetings.
Okay, thank you. I appreciate it. Now I think we're ready to move on to item number 4, which is really going to be the main part of this meeting, and is to discuss and draft proposed 2025 Response Subcommittee recommendations. We'll move on to the recommendation, which is recommendation number 1. And I will be addressing this as Committee Vice Chair Holmes was not able to make it today due to some family issues she had going on. So I definitely can't speak to it as eloquently as Dr. Holmes, but I will address this recommendation. This recommendation number one, I will note you have previously seen it as one recommendation, but we are now splitting this recommendation into three recommendations to accurately describe the actions needed for three of the substances discussed at our last meeting. Tianeptine was already scheduled, which would leave the mitragynine or kratom, Phenibut, and Amanita muscaria to be addressed. So that would then make that the first recommendation is recommending that mitragynine or 7-hydroxymitragynine or mitragynine pseudoindoxyl include any isomers, esters, ethers, salts, or salt of an isomer, any synthetic, semi-synthetic, or chemically modified derivative, and any compound containing mitragynine, 7-hydroxymitragynine, or mitragynine pseudoindoxyl as an active pharmacological ingredient, regardless of whether the substance is naturally derived, synthetically produced, or manufactured through chemical modification, be added to Schedule 1 of the Nevada of NAC 453.510. So I just wanted to highlight that there have been some actions taken since our last meeting to refine this recommendation, and the substances that we've talked about were addressed at the February crime lab meeting and discussed to get the input of the members of the crime lab. Myself, Dr. Holmes, and staff from SEI met with the Board of Pharmacy, and information was requested from Dr. Carla Wagner, who's an Associate Director, Center for Drug Use, Equity, and Policy Research at University of Nevada, Reno School of Public Health, and Marco Mendez, Public Health Evaluator with the Southern Nevada Health District, and Dr. Daniel Garrity, a Principal Research Microbiologist with the Southern Nevada Water Authority, who does the wastewater sampling. And the compounds were listed in the recommendations are detectable by the RADAR laboratory at the National Institute of Standards and Technology, also known as NIST, where both UNR and the Southern Nevada Health District, also known as SNHD, send their samples to have those tested. And just again, to refresh everybody's memory, those are samples that are submitted that are either off of paraphernalia or from drug samples. And then Dr. Garrity said that with the wastewater, it's possible to monitor for these compounds in wastewater, but there are a series of steps needed to develop and validate the method used before they can be implemented. Additionally, Dr. Garrity noted that these compounds are not yet included in their routine list, but that the Water Authority's research chemists identified mitragynine, also known as kratom, as a high priority for future inclusion. He noted there is a way to get information on substances that are not on their routine list, but it would not be quantifiable in the manner in which the other substances from the routine list are. And then SEI staff researched and reached out to other states, such as Utah, who addressed Phenibut in their 2025 legislative session. And then Dr. Knight, the Washoe County medical examiner, has done research, and it's cited under the first recommendation, also provided feedback. And luckily, we have Dr. Knight here at our meeting today. And I would open it up at this point, Dr. Knight, if you do want to add anything to the discussion on kratom.
Chair Kearns, this is Crystal Duarte for the record. I've noticed that Dr. Knight has come in and out of the meeting, so there may be some technical difficulties that she's having. So we might just need to give a second for her to
Get back in.
Yeah, and while we're doing that, I can click through. So Phenibut was mentioned as one of the updates related to that last list of things happening between meetings. So you can see on the screen that for recommendations, new recommendations 2 and 3, which were previously all bundled together. That is really just about standardized labeling, restricting locations for sale, and enforcement mechanisms. And that's the same as what is being proposed for Amanita muscaria. So we can get more into detail on recommendations 2 and 3 later. I do see Dr. Knight on the screen, so I will go back to this recommendation.
Great. Thank you, Dr. Knight, for being here. I wanted to offer you the opportunity if you had any insight or anything you'd like to add to our discussion on Kratom.
I'm wondering if Dr. Knight can hear us.
Yeah, I don't know. Doesn't look like it.
I will just check some messages, see if maybe she's communicating over email or something.
Her Zoom crashed and now does not have sound. Okay, she apologizes if anybody addressed her.
I will just note if you can join via phone.
Technology is great when it works, right? Dr. Knight, can you hear us yet?
I can. I'm on now. I apologize. I don't
No
know.
problems. We appreciate you being here. I was just going to say we were opening up the floor to you. We were on our discussion with our recommendation that includes mitragynine and noted that you had published on that. So wanted to offer you the opportunity if you had anything you wanted to add to the discussion.
Well, thank you for the opportunity to speak about this important topic. Yes, I published on the first 5 years of mitragynine-associated deaths in northern Nevada back in 2021. We saw our first death that had mitragynine involved in 2015. And in that first 5 years of having the drug present here in our population, we saw 35 deaths, and we published that, including the drug levels that were detected in the blood. Since that time, the total death toll for the Northern Nevada area that my office covers has risen to 102 deaths that involved kratom. And we're seeing now, unfortunately, that the other compounds that are listed here in the recommendation that I had recommended adding are compounds that are even more potent than mitragynine itself. The 7-hydroxymitragynine and the mitragynine pseudoindoxyl are both alkaloid compounds that are present in the kratom product itself, typically in very small amounts when we're talking about just ground up mitragynine kratom leaf. However, with these designer drugs comes a lot of ingenuity, and people have extracted the 7-hydroxymitragynine itself and can actually make that in the lab and then take the 7-hydroxymitragynine, and they are adding extra dihydro groups or an extra fluoro group to make it even more potent. So when we start out with mitragynine, that's been quoted as being about 13 times more potent than morphine. Then we get to the 7-hydroxymitragynine, which is more potent than the mitragynine, and then these other additional isomers and salts and other compounds being made from it are up to 240 times more potent, and that's what I've seen quoted for the derivatives that are being made from the 7-hydroxymitragynine. So all of that, not to bore you with lots of big chemical names, but all of that is to say that it's really important that we include these because we're now seeing kratom products called kratom that are entirely 7-hydroxymitragynine, and it's important that we don't just say mitragynine needs to be regulated. All of these compounds related to it need to be regulated. So I do believe the wording here does cover that very comprehensively, and I do think it's important that we regulate this in Nevada. I'm happy to answer any questions that are within my scope to answer. Thank you.
And I would just highlight that thanks to our members from the Board of Pharmacy and the Crime Lab, who really assisted us with this language on this to include those all the isomers with it. Are there any questions from any of the committee members for Dr. Knight while we have her expertise on the phone? Not seeing any. I would just highlight for everyone that this was the compound in one of the compounds of all of the four that Dr. Holmes highlighted that are sold over the counter at vape shops or at convenience centers, and felt it was often misleading because they're often coined as nutritional supplements or an energy drink or those sorts of things. So that was what really brought this to light for Dr. Holmes, and felt that oftentimes some people may know what they're getting, but oftentimes it's marketed to people who don't know as something else. So any thoughts on that, Dr. Knight?
That's absolutely right. These are frequently being sold in gas stations as well as online, and are often marketed in a way that would not make it evident that there is a powerful opioid in this. And people do become addicted to it. They can become tolerant and require even more and more of it, and then are going and looking for more potent versions of it. And so it can really lead to addiction when people aren't necessarily expecting that that's going to be an opioid. There certainly are a subset of people who are looking for the opioid, though, who may be even using mitragynine in place of other opioids. But unfortunately, with it being unregulated, they don't know what's in it, and they don't know the potency. And so that can be very dangerous.
And I would highlight in the discussion with the crime labs, they do have the capacity and do test for these materials that are listed here. The other two, they didn't recommend making them schedule, but rather have information about clear labeling on what's in them, and then the age restriction of 21. I would highlight that I was asked by the crime lab in the meeting why 21 and why not 18, and per Dr. Holmes' recommendation, it was because that's what we have for cannabis currently, is the age restriction of 21. So that was why we looked to the age of 21 instead of 18 for the Phenibut and mascara. Any questions or comments from any of the committee members on recommendation 1, 2, or 3?
I'm just shocked that the public isn't made aware of the hazards that these things present. I just I'm completely blown away by that.
Yeah, and I think that was really the impetus for Dr. Holmes bringing this forward. So, and Nicole, I know we reached out to you to ask if this was something that was tested for in your in the drug courts, and I think you said no, not at this point, but it could be added. Is that correct?
I received, I think they could probably add it. The response, I talked to some of the members on our team, and that was their understanding. So I would have to clarify it with the actual drug testing.
Thank you. It looks like Rob's trying to chime in, but we couldn't hear you, Rob.
Mr. Banghart, it does show that you're not muted on our end. If you're still on a phone, it might be muted twice. I've had that issue before.
Does he need to push like *6?
You could try *6. I don't know that that'll help because I don't see you as muted, but that's not a bad idea if you can hear us to try *6. So in
Oh,
the chat, he has asked, what is the half-life for that drug on drug testing?
for kratom, is it kratom you're asking about, Rob?
Yes.
Yes. Dr. Knight, do you know the answer?
Sure. I mean, if you're asking about the half-life in the body, it depends on the tolerance and how often someone is using that drug or other opioids, but it's been cited as anywhere from about 8 hours up to about 24 hours that it stays in the body. I'm not sure if that is answering your question, or if you're asking like how long we can detect it after someone dies. Basically, when someone dies, metabolism stops right then, and we're able to detect the drug as it was, at the time that they died when we do our postmortem testing at autopsy.
Thank you.
Oh, Chair Kearns, you're muted. I was just going to say, Mr. Banghart, we could hear you, so it sounds
Yeah.
like your issue
Yeah.
might be resolved.
Thank you. I'm having some difficulties this morning, but got it.
At this point, I just want to open it up and see if there's any other discussion on this recommendation 1, 2, or 3, or any suggested changes. I know we have Board of Pharmacy on too. If you guys have any thoughts as well, I would welcome those.
Chair Kearns, I would just also reference for members of the public as well as members of our subcommittee, a list of these recommendations was provided in a document. It's one of the meeting materials. So if you want to look at them in their full listing as how they would appear in the annual report, should they be approved and move forward, I would recommend doing so. There are several links to justify these recommendations, and it's really helpful to have members take a look at those things and fully understand what's being recommended. So I just wanted to note that as another way to spend a little bit more time with these recommendations before they get approved in the May, June timeframe.
Thank you for that. And in that document that Ms. Duarte is referencing, it gets into the research, it provides additional resources, what populations we would be affected, believe would be affected according to the legislation that we're supposed to be looking at. And then like timeframes and if it's a short term, long term, those sorts of things. I'm going to offer one more time. Any thoughts or any language? This is the document that Ms. Duarte was referring to. If anyone wants to look at it, it's on both the AG's website and was sent out to the committee members with our materials for today's meeting. I'm hearing none and seeing no one come off mute. So I think we're ready to move on to our next recommendation. And Dr. Knight, thank you so much for being here and providing your expertise to help guide us with these recommendations. You are welcome to stay, but if you need to leave, we totally understand.
Thank you very much. It was my pleasure.
Thank you. Can we move on to the next? So the next recommendation, which is now recommendation number 4, which was submitted by myself. This is a recommendation that we had previously submitted, and it's to recommend that state agencies under the legislative, judicial, and executive branches involved with deflection and diversion programs have a comprehensive definition of recidivism, and that would include desistance and standardized policies related to measuring and reporting recidivism. Additionally, that would require that all publicly funded or publicly administered reentry programs define success using clear behavior-based outcomes, and that programs articulate what meaningful behavior change looks like for participants using tools for measuring engagement, goal attainment, and behavioral milestones. And the update that we have on this is we reached out to the Bureau of Behavioral Health, Wellness, and Prevention within the Division of Public and Behavioral Health. And there's a note that they are going to be implementing the sequential intercept model, we also often call the SIM, in their strategic plan. And these selection and diversion programs and assistance do go into the SIM at different intercept points. And the Bureau is currently working to fill the critical positions to support work in this area. I also reached out to Washoe County Sheriff's Office. We had a presentation previously from them on their programs that they have running, and they highlighted that they're going to start the IGNITE program. IGNITE is all capital letters. It's an acronym, and the acronym stands for Inmate Growth Naturally and Intentionally Through Education. And this is a program that came from the National Sheriff's Association, the NSA, to help jails replicate a program that was implemented in the Genesee County, Michigan Sheriff's Office. And it offers comprehensive education, job certification, and post-incarceration work opportunities and assistance to incarcerated individuals. I would just highlight that in my conversations with TJ Mills at Washoe County Sheriff's, is that they haven't started this program yet. They hope to kick it off and start it. And one of the exciting things about the program that they're really looking forward to is that there will be a chance for evaluation through Stanford and one other university. I can't remember what the other university is, but they also offer through the National Sheriff's Association assistance with the implementation and maintenance of this program once it starts. So, and they, I think, have monthly or quarterly meetings with other programs that are have either implemented or are implementing the IGNITE program. So I just wanted to highlight those for you on this recommendation. And also the Office of Analytics has compiled some data, and they use persons discharged with programs with or without a conviction in 3 years after the program discharge date. But we are uncertain if that is being used as a working definition or just the definition they use to pull the data. I would open it up if there's any conversation or any recommendations for changes on this recommendation from committee members or discussion.
To talk a little bit more about the recidivism definition. I was trying to figure out, I couldn't remember the group that had worked on that definition, but it's the Nevada Sentencing Commission.
Yeah, and from what I
that.
understand, I was going to say, from what I understand, the only definition we have for recidivism in the state is from the Nevada Department of Corrections, and that's for someone to return to prison within 3 years. We have looked at the Wisconsin model, and in looking at the definition of recidivism, it takes other things into account. Is it lesser charges? What's the length of time since someone recidivated? What programs were they involved with, and those sorts of things, so that we're not just looking at, did they recidivate? Did they return to jail or prison within a certain time frame, but also looking at those behavioral based and programmatic types of programs to see what's working, what's not, what causes behavior change, and those types of program outcomes. I haven't seen anything else from the Nevada Sentencing Commission. Does that answer your question, Member Hicks?
You're suggesting we have to have a more detailed definition of recidivism,
Yeah.
besides what Nevada Sentencing Commission goes with.
Yes, because what we found, and I would highlight in working with some of the diversion and deflection programs, we're trying to measure things, and one program uses different definitions the other, so we can't even really compare one program against another because we don't have a definition. And we're really looking at these for programs that fund. So, for example, out of the Attorney General's office or DPBH, that they have a definition that can then be used by the programs that are getting funding so we can better evaluate the programs. And like I said, look at things such as time since they left, if they return, or looking at the different what the charges were. Is it a lesser charge? A civil matter? Was it a failure to appear? Those types of things, so that we can better evaluate the effectiveness of the programs. Peter, I would be interested to hear your thoughts on this recommendation.
Sure, yeah, I still agree with this recommendation. For all the reasons you just articulated, right? Like not every program's definition of success is should solely be based on recidivism, right? We certainly need other performance measures when we're trying to fund, especially new programs and obtain funding, and then also compare them to see which we should be implementing and which we should be abandoning over time. So I think creating a new, I do think using behavior-based outcomes, right, especially for things like drug court programs, for rehabilitative programs, instead of just measuring recidivism, we better get a better idea of what outcomes are rather than have they been arrested for something that may or may not be related to the underlying reason they graduated from drug court or whatever the other program might be.
Great, thank you. You articulated that so much better than I did.
You set it up really well for me, so made it easy.
Any other comments from any of the committee members or questions? Hearing none. And like I said, my only change would be on the recommendation to make IGNITE all capitals because it's an acronym, as I mentioned, for inmate growth naturally and intentionally through education, is the only thing I have. It's not on the recommendation, but just some of the background updates. I think we're ready to move on to recommendation number 5. Recommendation number 5, again, this one was submitted by me, Terry Kearns, and the description is to work with the Board of Pharmacy to include some type of safe disposal kits. That's not a brand, that's just a description, a safe disposal kit with opioid prescriptions and a one-pager with information about opioid overdoses, addiction assistance, look into how a prescription can be written for opioid antagonist when opiates are prescribed to reduce costs. And what I would highlight in this recommendation is that since our last meeting, I've met with representatives from the Fund for Resilient Nevada, FRN, who suggested really education targeted to seniors, for example, to a social media campaign targeted toward younger individuals, and then just a general media campaign about safe disposal of medications. And Dr. Beth Slamowitz suggested that the Board of Pharmacy do an education with pharmacists through the board's quarterly newsletter and perhaps a continuing education through the Nevada Opioid Center of Excellence, NOS, and also coordinating with the Nevada Pharmacy Association. And in this meeting with FRN, it was highlighted that in January of 2026, there were over 128,000 opioid prescriptions in Nevada. So in a meeting I had, I found out the cost of a Datira bag, which is one safe disposal kit. They're $4 a bag. So if you looked at the opioid prescriptions, that would be an estimated total cost per month to cover all opioid prescriptions of over $500,000. Or if you extrapolated that amount to 1 year, it would be over $6 million for 1 year. Everyone in the meeting agreed that's not a good use of the opioid litigation funds because some people will not even use these kits, but rather to look at the education campaigns and then look to our prevention coalitions who already do distribute the Datira bags. And let's see, I'm sorry, I'm looking at my notes. I met with Jamie Ross, who's the executive director of the PAC Coalition, and Wendy Nelson, who's a SURG member and the executive director of the Frontier Community Coalition. And they agreed that the prevention coalitions across the state could take the lead in distributing the disposal kits. And then we also reached out to Ohio, and an email was submitted that basically described Ohio's RX disposal about medication safety policies and resources. And the respondent from that email said that as far as they know, Walmart provided Datira bags with all health through the health department or through county mental health, addiction, and recovery service boards. However, CVS has a policy where they either have a medication disposal box or they will provide a patient with a disposed RX packet when an opioid prescription is filled. And they also said they have a statewide SPF prescription grant through the Ohio Department of Behavioral Health that allows them to provide Datira bags to any Ohio resident at no cost through the Ohio RX disposal. And our state has an extensive substance use, this is Ohio, has an extensive substance use prevention network. So there has been a lot of advocacy to get state funds separate from treatment resources that allow for medication disposal resources to be available. Ohio also is unique in the sense that there is a lot of collaboration between agencies across the state. So often they provide a bulk amount of resources to local pharmacy health departments who in turn distribute directly to community members, all at no cost due to grant funding. There are not any regulations or policies that require accessible disposal options in the state. It has purely been done through persistent community education, advocacy, and collaboration between public health agencies. And they highly recommend one agency being in charge of ordering the Datira bags. They have a tiered pricing system, and it is the most cost effective per bag if all the money is spent from one account. So given that, that's why we made the changes we did to the recommendation. And the proposed revision is work with the prevention coalitions to make available Datira bags for safe disposal of opioid prescriptions and to provide education to community members. And then work with the Board of Pharmacy to include a one-page document with information about opioid overdose disposal and available addiction assistance. So that's what we came up with because it's not economically feasible or a good use of those opioid litigation funds to give out a disposal kit with every prescription. So I was going to say, did you need me to repeat that, or if you have it?
I think I'm going to be able to get it on the slide there. So yes, I think that's showing up for everyone, right? And the justification would be the same. I don't know if the action step is changing, but we can note that here as well.
Yeah, I think the action step is rather than have the pharmacies provide that, is the action steps would be to have the prevention coalitions take the lead in providing the Tatira bag, in purchasing and providing the Tatira bags to members of the public. With opioid prescriptions. Technically, they provide them to anyone who asks, but in this one specifically, we were looking at opioid prescriptions. And then also for the prevention coalitions to do community education with with seniors or senior centers. And to do a targeted education toward youth and have a social media campaign on safe prescription disposal. In this case, we'd say safe opioid prescription, but it's technically all. And then the funding again would be requested for the Fund for Resilient Nevada to fund this effort. Any comments, questions, or proposed changes from any of the committee members?
I have a question. When you
Yes.
say, when you say prevention coalitions, can you be more specific exactly what you mean by that?
The prevention coalitions that do prevention for behavioral health and substance use, so such as PACT Coalition here in Clark County, the trying to think of where Wendy was from, the Frontier Community Coalition.
Okay, so organizations that do that. Okay.
Yeah, that are already recognized by the state as prevention coalitions. And I know they're also getting into certification for certified prevention specialists. Does that address your question?
Yes, ma'am.
Thank you. Other questions or comments from committee members? I will say, when I found out the number of opioid prescriptions for 1 month, I was a little taken back by that. So, and Dr. Slamowitz, having previously been a retail pharmacist, did say this is something that really shouldn't be put on the pharmacist or the pharmacy techs at the farm. They already have enough that they do. So that was also a direction in reaching out to the prevention coalitions. And the other piece was, I know that I had gotten some feedback that somebody went to a pharmacy to get a free free naloxone because they had recently gotten a opioid prescription. And the first person they talked to said that they didn't do that. But then they went and talked to the pharmacist, and the pharmacist said, yes, we did. And the person was able to get a free naloxone from that pharmacy. So that what led us into also, and at Dr. Slomowitz's recommendation that maybe there should be some education, not necessarily in person, but thought if NOCI had a virtual that the pharmacists could take it and where there were CEs provided. And then also our members from the Board of Pharmacy, if they could push something out in their quarterly newsletters that they already do. And I would ask you, BOP member Weist, do you have any thoughts or comments about that?
I think the Dave Weiss, for the record, you guys are the policy makers. We'll follow what you tell us to do. We no longer have the quarterly, but we have an on demand, so we'll do it on demand. So we could definitely meet that. We with the internet, we've become more interactive with the licensees than just putting out a quarterly with no feedback. So happy to do whatever the subcommittee recommends and can pass.
Okay, and if we did come up with an online education with through NOCI, would that be something you'd be interested in assisting
Absolutely.
them
We,
with?
we would do that, no issue. And we can actually send it. We have about 15,000 prescribers that are registered with the board too, so we can get it to the doctors and the pharmacies.
That's great. Thank you for that input.
Okay.
One more time, I offer any comments, any suggested changes or questions from committee members?
Can I say one more thing? I I agree with everything that's on here. I do disagree with the not using it at the pharmacies. I feel like it's for me, I feel very much like anywhere this is, it should be accessible. That's just my opinion. I feel like at the pharmacy, it should be there on top of education, on top of all the things. I feel like, and this is not an attack on pharmacies in any way, shape, or form, but if you're dealing with this, you should be responsible. There should be both sides of it there. And I'm not saying that they're not, they do great work. I just not everybody has social media. Not everybody's going to come in contact with the coalition, right? Like anywhere that you do have contact with them is an opportunity to educate, and it should be happening at that point. They know right away, hey, if you don't use all this, here's this bag. Hey, if this happens here, I think we should be utilizing every opportunity and not focusing on just because it seems like we're shifting the responsibility into the community, which is all good, but not by itself. It should be at every step, in my opinion.
That's a great comment, Rob. Thank you for saying that. And what I failed to mention is that the prevention coalitions are going to work with the pharmacies. So I don't know if that's maybe leave them some bags, maybe, leave them some education. So that is one other piece of this is that the prevention coalitions will establish relationships with the pharmacies. And I believe there's 600 or 650, if I remember correctly, from what retail pharmacies, but within each of the coalition's area of responsibility, they would work with the pharmacies to provide, their information or to provide these one pagers and things. So they're not totally left out of it, but we wanted the lead to be through the prevention coalitions. But thank you for that comment.
Thank you.
Chair Kearns, I don't want to interrupt member comments, but I had a clarification on the action step.
Okay.
You mentioned online education with NOS. Did you want that to be included? And if so, we can work offline, but I just didn't know if I missed that.
Yeah, I didn't say that as an action step, but that probably would be one too, is to add that in an action step to work with the NOS to get an online CE education for pharmacists, pharmacy techs. And online continuing education. Pharmacy technicians, pharmacist. Thank you for pointing that out. And as Ohio so nicely noted for us, if the prevention coalitions take the lead in purchasing, they'll get a better deal buying them in bulk. Okay, I'll open it one more time. Comments, questions, or any requested changes? I actually do have one question for both members. Let me get it up here. I'm so sorry. For members Handy and Hicks. Do you guys have the ability to get this type of stuff for people you interact with? Would it be worthwhile to have the prevention coalitions reach out to your groups as well?
Actually, I think it might not be a terrible idea, and we wouldn't need many of them, but I think we should always have something.
Okay, and then their one pager they have too, that I think most of them already have it, but so maybe reach out to the drug courts.
To Brooke Howard, who's the coordinator for all of the specialty courts, not just drug courts. So
Who was that? I'm sorry, I didn't hear the name. All I heard was Howard.
you can email me and I can get you connected.
Perfect, thank you.
Yeah, and from my perspective, the same, right? I think it'd be helpful to get like a one-page information sheet, especially in the more rural areas where there isn't as much immediate access to the kind of providers we typically see in the larger areas.
Okay, great. And we could add that too, is for the prevention coalitions to connect with the specialty courts, drug courts, and also with the DIDs.
Yes, that'd be great.
Excellent, thank you. All right, I think we're ready to go on to the next recommendation. Which is a placeholder for a draft recommendation. So at this point, I'm going to open it up and see if any of our members have any draft recommendations they'd like to bring forward.
This is Bud. I'd like to throw something out just for a really brief, quick discussion if it would be appropriate as far as the potential recommendation.
Please do.
As you all know, the Crisis Stabilization Center, which UMC has put up with the county, one of the primary focuses is being able to interact and support individuals who come in contact with either the health system or law enforcement due to substance use disorders. And once an individual comes into the CSC, they're wrapped around a number of different interventions, including peer support specialists, and working through to get them into a recovery program. The key is that they've got to make it into the Crisis Stabilization Center in order to have the opportunity. Oftentimes, EMS, as well as even the crisis response teams, will end up taking the individuals to an ED. And then it's going to be really hit or miss whether or not they have the opportunity to get involved or exposed to even peer support specialists. The Southern Nevada Health District has created a set of protocols, and those protocols are suggestive of taking these types of individuals into to the CSC, or their words are even less than that, just be transported to an approved alcohol and drug abuse facility rather than the hospital emergency department if the patient meets all the criteria and it's all medical related. I'm wondering if there's not something that would be worth at least making a recommendation to the various health districts that cover the state to adopt a similar protocol that is more prescriptive rather than should be transported, is to be transported to an approved alcohol drug abuse facility. I'm just wanting, or doing some other wordsmithing to get them to the appropriate levels of care. I have an issue with drug abuse facility because some take Medicaid, a lot don't, and it's a lot more payer dependent on whether an individual is going to be able to accept or be accepted into a program. So I would be happy to draft a recommendation on wording that would be more of an encouragement to the health districts in the state to adopt, and then get a little bit more prescriptive wording in terms of where available, take these individuals to a crisis stabilization center. That would do two things. One, to make sure that patients would get to an appropriate intervention spot. And CSCs only keep patients for no more than 24 hours. It truly is an intervention, and then getting individuals into an appropriate care setting from there, without regard to their ability to pay. And I think if we created something that the health districts would be more prescriptive to go to CSCs if available, that would help for other entities to reconsider whether they would want to stand up a CSC, given the stronger encouragement, if not almost prescriptiveness, to EMS and other entities to utilize the CSCs where available.
Can I ask you a question? But I have an understanding. I want to make sure it's correct. It's my understanding that EMS cannot get paid in transport to a CSC. It's transport to an ER. Is that correct?
You know, that's something that I was under the impression that there is a payment differential. I think they still can get paid, but I believe that it's much less. I'm still trying to figure that one out. I've gone to a number of sources, and it's not a simple piece to uncover.
And additionally, currently the only CSCs are in Clark and Washoe, correct?
Correct.
Yeah. So that leaves our rural and frontier counties with either a long transport or not having the capacity. So that is part of your justification for looking to open more.
Right, and there'd be the caveat where available. We wouldn't expect somebody to drive 30 miles or 100 miles to get someplace. But yeah, I think that would do those two things. One, to help get the right patients to the right place at the right time, but also provide that incentive and more assurance to others that would consider opening up a CSC. And you don't have to make it 20 people or a 20 patient facility. It can be 6 or 7. Mallory's got, I think, a 10-bed unit. So it doesn't have to be huge. And so it doesn't have to be a giant investment from various providers to open one up.
It's Crystal Duarte, for the record. I just was going to note what Mr. Shaw was just saying, that when we reached out to potentially have presentations from the CSCs in Nevada, we reached out to Bud, Mr. Shaw, for UMC and Renown, as well as the center that he just mentioned, which is Mallory in Carson City. So I believe there might be 3.
There are.
Thank you for that clarification. And the other thing, I believe this was discussed, not this CSC, but it was discussed in one of the other subcommittees, the treatment subcommittee, that in the emergency departments, unless it's a psychiatrist, the addiction specialists don't have privileges in the hospitals, so that's why the referrals are often not made unless it happens to be a psychiatrist. Is that correct also? Do you know?
It is to some extent. We do have, it really depends on if they've got any access to peer support specialists. Jamie's team, PAC Coalition, does work to place peer support specialists inside the EDs. So if you've got some sort of a mental health, behavioral health clinician in there, they can encourage the physicians to make a referral. But for the individuals to come into the EDs and interact with the patients does require some level of credentialing, and typically medical staff credentials don't extend to non-medical individuals.
Thank you for that clarification. I'm sorry, I've taken over with all the questions. Do any of the other committee members have any questions or comments? I'm actually going to ask our member Banghart. I know you do a lot of outreach in the community here in Clark County. Were you aware of the CSC, and is that a facility that you can take someone to if needed, or have you taken people to if needed?
We are aware of the CSC, but typically no. I think our continuum of care is we have detox, we have triage, so we don't have a need for that. I think where we would see that is particularly for us, we deal with substance use disorder and homelessness. So if they are not requiring of those services and unwilling to go straight into sober living so we can get them case managed, then we would. For us, it would be a last. You know what I mean? It's the shelter or that, because we've created a safety net in that arena that we don't need that. I think that was more of a crisis intervention, let them stabilize and then filter them through the system. The issue that we see, and there's without a true continuum of care in Clark County, I also work at Crossroads, which would be the next step in care, right?
Right.
But we don't see a ton of referrals coming from the CSC because nobody's watching. Even though it's county money all the way through, we're not getting the referrals to the next step. If the CSC is, let's say it's got 60 beds, I would have to imagine that if it's a 24-hour stay, that we would be getting a certain percentage of that, right? If we're the continuum of care, the next step, but we're not seeing that. So there's a disconnect there as well. As Shine a Light, we've just, like I said, created our own path. We know what to do. So the CSC isn't really vital. I think it's better for maybe those that don't have any experience, don't know what to do. They stumble across the CSC, they go in. Hopefully that would be the starting point to get them connected into a continuum. That's not what I've seen.
Okay.
So I guess, Rod, the one thing I would say to that is that one of the challenges at the CSC is, yeah, we're ready to take 50 patients a day. Right now, we're averaging about 8. And that's not just SUD. That's a combination of all of the above.
So then it's even the awareness, right? That it's there, that it's doing the
Well,
work that it's doing.
Yeah, it's a combination of awareness, but more breaking the legacy habits of EMS in total.
Yeah.
Because that's where I see the major disconnect. And frankly, our largest source of folks coming into the center is EMS, and right behind EMS, within maybe year to date, actually since opening, there might be a 50 to 100 person differential is self-referrals, folks walking in for help directly.
do you guys see a lot of foot traffic? Like I know the location, when I first saw it, I thought there's not a lot of traffic running through, right? Like there's traffic, physical traffic, but I mean like, is there a lot of unhoused in that area? Is there a lot of,
Believe it or not, it's not unhoused. Um, it's folks that either drive up or walk up. Um, and right now we've had, I'm looking at my referral sources, but roughly a total of about 600 patients have come in through, not even that, 500 have come in through the EMS system. And we've gotten roughly 400 that have walked in. They're self-referrals.
that's a great percentage.
Yeah, it is. And we actually have, looks like we have gotten referrals from Crossroads, speaking of right at 500.
That's good. Any other questions or comments from committee members?
Chair Kearns, I have a question for you and the committee. Would you like me to put some draft language on that slide to review, or where are we at in the process of, and I think for you, Mr. Shaw, as well, where do you want to be in the process of moving this forward or revising it, for further developing it?
Yeah, I think we need some further development. I think it's, in my opinion, good for starting it. This may not be one that's fully vetted out by our August 1st deadline for this annual report, but I'm definitely in favor in putting some draft language to get it started. Bud, does that sound good?
Yeah, I'd appreciate that. That was going to be my question too. Is what can we do? So that's great. Appreciate that.
So can we put submitted by Bud Shaw? If you're ready to.
I will add that sorry, I've moved away from that slide even though I have
Yeah,
a
no,
question.
sorry. It's okay. And then description. Okay, you already got some.
I also heard a slight difference to this, which would be recommend health districts adopt a protocol that requires transportation to an approved alcohol and drug facility. So I can also put that as it may be one or the other, or those are the ideas. Those are at least the concepts that are being worked on at this point.
Well, I'm actually going to meet with SNHD on Monday, so we might even be able to come up with some refined language by then. And Rob, perhaps you and I can connect and we can see if we can wordsmith some things to work, that would work for you as well.
Sounds good. Yeah, and I think we'll need to go through our other document that you have to get like the justification and research and all of that. Action steps. But that looks good for a start to me. Again, I'll
Thank
open
you.
it up. Questions or comments from committee members? Okay, hearing or seeing none, I think we're ready to move on. And we will work on this recommendation. So we're on 5 to review the 2026 Response Subcommittee meeting topics and timelines. We have the following was reviewed at the prior subcommittee meeting with some minor changes were made. These are bolded in the slides, and it's possible the subcommittee won't need to meet in June if feedback received in May is incorporated and approved at the June SURG meeting. So we have March, which we're doing currently. Then May 2026 would be finalize and rank our preliminary recommendations for the presentation at the June SURG meeting, and then any subject matter expert presentations as requested. And again, June, if needed, finalize our recommendations based on the feedback from the SURG. And just for any new members, some of the feedback we will get is, changing or adding something from the SURG, or if there's another subcommittee that has something similar or along the same line, sometimes about combining those recommendations. Those are the kinds of things that we've seen in the past. Or if we need to research something further, sometimes recommendations will be made about talk to this group or that group, and those sorts of things. That's typically the kind of feedback we have gotten from the SURG. And then September, November, December 2026, we start the new reporting cycle. So again, our annual report is due on August 1st of this year. So if you have any speaker recommendations, please submit those to SEI staff. And it sounds like we might have some more work on this latest recommendation we just came up with, but it sounds like we might be pretty good on our other ones. Moving on to the full SURG is April 2026 presentation on peer certification and the state budget process, and an update from the Fund for Resilient Nevada, and then review our preliminary recommendations from each of the subcommittees. In June of 2026, review final ranked recommendations and approve the 2025-26 annual report template. And then July 2026, approve the 2025-26 annual report. And then in October 2026, presentations from subject matter experts. And we also going to do an overview of open meeting law that's pending, just with some questions that have come in to us. So that's our kind of current cadence of our subcommittee meetings and our full SURG meetings. Can go on. And planning for the 2026 response subcommittee. Again, please email subcommittee staff with any speaker recommendations you might have, so we can get those scheduled. Any questions, comments from subcommittee members? Hearing or seeing none, I think we can move on to the next item, which is item number 6, public comment. Again, public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. No action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken per NRS 241.021. Please do not use the chat for items other than technical support again, or if you're a member of the public and you want to be recognized for public comment. If you're dialing in from a telephone, dial 719-359-4580. When prompted, enter the meeting ID of 884-0825-1817 and press *6 so the host can prompt you to unmute. Members of the public are requested to refrain from commenting outside the designated public comment period unless specifically called on by the chair. Do we have any public comment? I'm not seeing anyone come off mute or any hands raised. We'll give it just a minute longer. Do you see anyone, Ms. Duarte?
I do not.
Okay. And I don't see anything in chat. At this point, I think we can move on to the next agenda item, hearing or seeing no one for public comment, which is the adjournment of our response subcommittee member meeting. So it is 1:21, so I will gladly give you back 9 minutes to your day. Thank you, everyone.
Thank
Thank
you.
you.
Meeting
Thank you.
meeting is adjourned.